The decade has ended, the year has ended, but this Puscast keeps on keeping on. Welcome to the Persiflager's Puscast, a review of the infectious disease literature with commentary for the last 2 weeks of December 2009. Say farewell to the aughts. We're now into the debts, I guess, great big debts. Brought to you by Pusware LLC, publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion. Your Uber hyperlinked electronic guide to infectious diseases at Pusware.com. This is CME accredited, so I have to say this stuff over and over again with each Puscast, but there are no conflicts of interest from this Puscast, except, I suppose, the meager income I derive from the generous donations of my listeners. Then you can go online, take the quiz, and get a free half an hour of CME. Thank you, Legacy Health System. As always, participate in my expanding multimedia worldwide empire with my Gobbet O Puss podcast, my Quackcast podcast, voted top health podcast by the listeners. Rubodorlor Kalor Tumor, he says very quickly, my infectious disease blog, and of course, science-based medicine blog, because the world needs more Mark Crislip. Yeah, you knew that. And as your New Year's resolution, as I said on other podcasts, I know you're not going to stop smoking. I know you're not going to lose weight. I know you're not going to give up heroin. But you can still go and write me a review on iTunes. The references are, as always, available at the website. And now let's move on to the literature. I'm going to start off with some useless information. Now, I'm usually interested in infections that involved human beings, but as I was preparing for this Puscast, I noticed there was a virus called the cricket paralysis virus. And I thought, boy, that would be terrible in England. What if they had a soccer paralysis virus? But I went and looked, and there's a family of viruses called the Dicystroviridae that infect aphids, leafhoppers, flies, bees, ants, and silkworms, and have in their family other viruses that are known as things like the cricket paralysis virus, the honeybee paralysis virus, the aphid lethal paralysis virus. These are not pleasant for insects, I would suppose. But I just sort of like the fact that there are aphid, bee, and cricket paralysis virus, and these viruses can affect far more than just those insects. So next time you're walking down the street, and if you see an aphid lying on its back going, "Help me, help me," you know that you have aphid paralysis virus in your neighborhood. Now let's move on to more important stuff. I rarely talk about hepatitis C in this Puscast, mostly because I don't treat hepatitis C. For historical reasons in Portland, it's been the gastroenterologists that have treated hepatitis C. But this article is interesting in that it expands the importance of vitamin D in infectious diseases. Yes, vitamin D, it does more than build strong bones. It's an important factor in the immune system. Now, having extra levels of vitamin D doesn't do diddly squat. If you're therapeutic, you're therapeutic, and putting more gas in the tank doesn't make you run better. But if you're deficient in vitamin D, as most of us are in this gray times, then you have worse outcomes with infections of a variety of types. This looked at the response of patients receiving interferon and ribavirin for hepatitis C, and them what had low vitamin D levels had a worser response to interferon and ribavirin. So virtually all patients should probably have their vitamin D levels checked unless you're in San Diego and spend your days sunning on the beach. There was a time last century when I was not very aggressive about getting my AIDS patients to stop smoking, because they're all going to die. And if they're going to enjoy their life, and tobacco was an important enjoyment for them, I didn't see the sense in getting them to stop smoking. That is no longer true in this era of highly active antiretroviral therapy and immune suppression, because patients now live a long time, and what they get are cancers. A recent study looked at the risk of cancers in 625,000 patients who had HIV, pooling 18 studies. And they found a wide variety of non-age-related cancers are at increased incidence in patients with HIV. They found that the standardized incident ratios, whatever the hell those are, were 28 for anal cancer, 5.6 for liver cancer, 11 for Hodgkin's lymphoma, 2.6 for lung cancer, 1.7 for kidney cancer, 1.5 laryngeal cancer, 8 for leukemia, and 4.8 for brain cancer. AIDS patients or HIV patients are at big risk for the development of a wide variety of malignancies. Probably the importance of immune surveillance is busted in these people. What to do in terms of surveillance got me, but it's the whole heightened index of suspicion in HIV patients and the importance of modifying risks like tobacco. The flu pandemic was not as bad as we had feared, thank goodness. But still, for some, it was still not such a hot thing to participate in. Of the deaths reported to the CDC so far, 10% were in pregnant women, a disproportionate number of deaths in that population, and a significant percentage were primarily in children and young adults. It was a disease that killed, when it did, the young and the pregnant. There was a recent article that looked at the autopsy series of 31 patients who died of pneumonia and influenza. It's always best to do autopsies on people who died. Living patients tend to object. And they found 3 patterns of pathology in the lungs of them what died of influenza. 9 of the patients had what was called classic exudative diffuse alveolar damage. Another subgroup not only had diffuse alveolar damage, but it was combined with severe necrotizing bronchiolitis with extensive necrosis of bronchiolar wall and bronchiolar lumen density. And 5 patients had diffuse alveolar damage with an intense hemorrhagic component. The rest of the patients had no real changes that were unique. The other interesting thing, which keeps showing up in these series of autopsy patients, is the number that had a secondary bacterial infection. In this series, 38% had a secondary bacterial infection. So when should you treat patients who are dying on the vent of influenza for pneumonia? Probably all the time, since it's so difficult to definitively diagnose ventilator-associated pneumonias in the hospital. Part of what made the flu season somewhat less bad than it could have been was the relative lack of infectivity of this particular H1N1 compared to standard strains of influenza. It really was kind of a wimpy virus. A study in the New England Journal of Medicine looked at household transmission with the H1N1 pandemic strain, and it was distinctly unimpressive with how aggressive this virus was at spreading within households. Overall, 13% of household contacts developed influenza after being exposed to an index case, which is lower than you'd usually see with seasonal influenza, which is around 10 to 40%, and averages about 30. It was, however, an age-related transmission. 0 to 4 had the highest chance of getting influenza. If you were 5 to 18 years old, it was a little less. If you were 19 to 50, the estimated odds ratio of acquiring influenza was 1.0. And if you're an old geezer like me, greater than 51, by gosh and by golly, your odds ratio were 0.41. My kids, I think, both had a mild case of influenza, and neither my wife nor I, old geezers both, didn't get sick with flu. So when you send your patient home to be cared for by their alleged loved ones, the old ones are the safe ones not to get influenza, but to keep them away from the 4-year-old. And especially, of course, the pregnant women. And even more importantly, a pregnant 4-year-old. Does the flu vaccine work? I get asked that all the time. And the question is, yeah, kind of like how seatbelts work. Do seatbelts prevent all injuries? Nah. Do seatbelts prevent all deaths? Nah. Are you better off with a seatbelt than not? You betcha. And that's because it decreases the odds of getting an illness. How good is the influenza vaccine? This was a nice study. It was a randomized, placebo-controlled, prospective, unfortunately in the healthy young, age 18 to 64, who were randomized to get either the trivalent vaccine or placebo. So how good was the vaccine in preventing influenza in a group of pretty healthy, youngish people? Well, for H1 influenza A, not the pandemic strain, but the usual circulating strain, there was one case of influenza in the placebo group and none in the vaccine group. For the H3 influenza, there were 77 cases in the placebo group and 57 cases in the vaccine group. For influenza B, there were 3 in each group. Both were unmatched to the vaccine. So how good overall was the vaccine in preventing influenza in this group? And this was culture-proven influenza. So it was nice that way, and that they did cultures to see if patients had the flu or not. The overall efficacy rate was about 66% for matched strains. So it's kind of like wearing a seatbelt. If you're going to plow into a wall, you're probably going to die no matter what you have on in terms of protection, but you're better off to have one than not. And the same goes with the flu vaccine. The flu vaccine is not an all or nothing like it is for, say, tetanus. One of the big reasons that medicine is a pain in the butt to try and practice is the data keeps coming in and changing what you do with your practice. Now, this study looked at the results of dexamethasone and or glycerol in kids with bacterial meningitis. Now, the reason that dexamethasone and glycerol are given is that supposedly they decrease neurologic damage, primarily manifesting as hearing loss. This study treated kids between 2 months and 16, and they were given ceftriaxone for their bacterial meningitis, but they were given either dexamethasone, glycerol, both, or placebo. And at least in this study, the bummer was that they had the same amount of hearing loss in all groups, and that the decider for hearing loss was not the therapy, but on how bad the meningitis was at presentation. So we have another study that muddies the water in terms of whether or not adjuvant medications are of benefit in bacterial meningitis in kids. It's one of the reasons I'm thinking of changing to alternative medicine practices. I'll never have to learn anything new. It's just so much easier. Infectious diseases are all about associations. And no, not Alcoholics Anonymous, which is a worthy association nonetheless. Rather, you think about certain exposures classically leading to certain infections. Classic is bongo drums or drum skins. Now, anthrax is endemic all throughout Africa, and the animals can have anthrax on their skin. The spores are quite stable, and so people who are exposed to African drum skins can get, yes, anthrax. And indeed, such a thing happened in New Hampshire, where a lady got sick with abdominal gastrointestinal anthrax. She attended a drum beating ceremony at a local religious ceremony where many of the drums came from Africa and had animal hide coverings. They hypothesized that she inhaled the anthrax spores as a result of being exposed to the religious drum circle. And it probably wasn't her drum, but somebody else's African drum. See, these classic exposures really do occur. And why ID remains the coolest of subspecialties. You kiss your spouse with that mouth? They always say that when people swear. But when you look at the bacterial flora of the normal oral cavity, as they did in this study, it can be, figuratively speaking, jaw-dropping. It is estimated that there are probably 25,000 phylotypes in your mouth alone. Now, they went and looked at 3 people's mouths by advanced sequencing techniques looking for DNA of various and sundry organisms. And they found in 3 people 3,600 unique sequences, including 500 different species-level phylotypes and about 104 higher taxa. And that was just in 3 people's mouths. It's been estimated that we can grow maybe 5% of the organisms found in and on our body. That's probably, based on these types of studies, a vast underestimate of the number of bacteria that use us as sentient transport media. And then you have to take into consideration where your mouth might wander. The next study we're going to talk about concerned urethral cultures for chlamydia trachomatis and Neisseria gonorrhea in men who have sex with men who only received oral sex. And in this study, where they looked at all patients who sought care at a San Francisco STD clinic, they found that the rates of chlamydia trachomatis and Neisseria gonorrhea in men who said that in the last 3 months they'd only received oral sex was 4.8% for chlamydia and 4.1% for Neisseria. So it would appear in this population that oral sex is as good as transmitting chlamydia and gonorrhea as unprotected insertive anal sex, which resulted in the same urethral positivity rates. My recurrent theme in medicine is no good deed ever goes unpunished. Same is true for central lines. And I think about a year ago there was an article in the Annals about central venous catheter-related endocarditis. This is another series on this particular problem and is interesting. Over an 8-year period, they defined 24 patients who had catheter-associated endocarditis. 15 of them were not considered nosocomial, 9 were considered nosocomial. And those who are in-house had a 1 in 5 chance of dying, which is pretty good. Not unsurprisingly, they had diabetes and chronic kidney disease and prior valve problems. What was interesting was the microbiology. Staph aureus accounted for about 50%, but the other big organisms are coag-negative staph, about a third, Candida, about a fifth, and Enterococcus, about a sixth of cases. And 5 of the cases were polymicrobial. The other thing about this particular case series is that about half the cases require transesophageal echo to make the diagnosis, something I don't routinely do in my line-related bacteremias. But I tend to get my TEEs done if I have a high index of suspicion and it's going to alter therapy. And even with all our bundles for the prevention of catheter-related line infections, which have driven the line-related infections in my hospital to almost zero, there can still be very disastrous complications of putting central catheters into patients. Where would the world be without Olmsted County, you know? I did my residency in Minneapolis, Hennepin County, and we used to always say, hold the Mayo. But be that as it may, the Mayo Clinic is the source of a lot of good epidemiologic data. And this looked at temporal trends in Staph aureus bacteremia in Olmsted County between 1998 and 2005. And here's the interesting thing, as all people are not surprised to find out, there was an increase in the proportion of infections due to MRSA over this 8-year period. Big duh there. But the interesting thing is, I think, is that during this time frame, the episodes of Staph aureus bacteremia remain stable. So what indeed has happened over the last 8 years is that MRSA has supplanted MSSA in the community. Now, we all suspected this was going on, but the more interesting question never answered is why. Yeah, sure, MRSA has some virulence factors that would make it more likely to gain a toehold in people, like that there Panton-Valentine leukocidin, don't you know? But as a rule, resistant organisms are less fit in an antibiotic-free environment. So it is yet to be explained evolutionarily why this MRSA has come to the forefront, or even the 3 front. Now, water's wet, fire's hot. Staph aureus bacteremia is bad. Well, what factors are associated with mortality in Staph aureus bacteremia? at least in Germany in the 521 patients studied. Well, all-cause mortality was increased from Staph aureus bacteremia if you were admitted to the ICU. Okay. Had MRSA. Fine. If you were older than 60. Sounds good. If you had endocarditis. Yeah, that's always bad. Or if you had a non-fatal underlying disease comorbidity, like diabetes. Yeah, all those things were associated with an increased risk of dying of Staph aureus bacteremia. What is protective? Are you ready? An infectious disease consultation. Quote, these data suggest that the outcome of Staph aureus bacteremia may be improved by expert consultation service. So, next time you have a Staph aureus bacteremia, give your ID doctor a call. You'll be the better for it. This self-serving message is brought to you by the Infectious Disease Society of America, the maker of the world's best infectious disease doctors. Elucidate. What is the role of Pseudomonas aeruginosa in COPD? What can you elucidate about that organism? There's been some data of late to suggest that Pseudomonas is an important organism in COPD in that it causes exacerbation and perhaps more rapid worsening of lung function. It turns out from this study in CID that Pseudomonas in COPDers is not the same as Pseudomonas in cystic fibrosis, where it is a major problem in the colonization and worsening of lung function. In the CF patient, they tend to get a strain of Pseudomonas that hangs on. COPD patients in this study, where they looked at a large number of isolates over time in a large population of COPD patients, found by genotyping that in the COPD patients, Pseudomonas colonization is a transient phenomenon. So patients get a little Pseudomonas, they get some exacerbation of the COPD, and then the Pseudomonas goes away. This would tend to suggest that you do not need to pound on the Pseudomonas in the COPD in the same way you do in a cystic fibrosis patient. But more elucidation needs to be done on this organism. It's sometimes the little things or the not so little things that make a difference in disease. This study looked at invasive pneumococcal disease in Alaskan children way up north in the Yukon area, which has an extremely high rate of invasive pneumococcal disease. And they looked at the results of the vaccine. They found that the vaccine resulted in a drop of invasive disease by 60% for those strains covered by the vaccine. But then, unfortunately, the non-vaccine covered serotypes popped up and were at a rate 5 to 10-fold higher than other Alaskan children. Now, they found that the other thing that was associated with increased invasive disease was a lack of piped-in water. The rates of those that did not have piped-in water were 3 times higher than those that did. And they postulate that the reduced water supply led to limitations in hand washing and other basic hygiene to help spread the pneumococcus. I sometimes think we lose track of what a miracle, though not really a miracle, of modern engineering the water supply is, and how we can just turn on the faucet and have a cold glass of water and wash away our infections. I feel like I should break into song here from Oklahoma. I'm gonna wash that bug right out of my hand. Nah. You want to have needleless systems in the hospital because it prevents needle sticks in our employees and subsequent risk of acquiring infections like hepatitis and HIV. However, trying to figure out the optimal needleless system is never straightforward. There's the split septum systems, and then there's also the mechanical valve needleless systems. They had 5 hospitals in this report that switched from the split septum connectors to the mechanical valve needleless connectors, and as a result, all their line-related infections went up. So that if you have to be careful when you make a switch from your system, that you're not going from bad to worse. And you never know when you suddenly change your mechanics what sort of odd things are going to happen that might increase infection rates. One of my hospitals, one of the surgeons decided to use this subcutaneous pain relief system where a lidocaine-like substance was irrigated into the wound. Subsequently, he had a big spike in his wound infections. No good deed, remember, ever goes unpunished in medicine. You got your SIRS, Systemic Inflammatory Response Syndrome. SIRS is usually defined as two or more of the following: fever or hypothermia, tachycardia, tachypnea, elevated or lower white count. This is before an infection is defined. Now, most SIRS studies have looked at the ICU. This study looked at 437 consecutive patients with SIRS in the emergency room and what happened to them. People who had SIRS had a much higher rate of subsequently being discovered to be infected, and they also had a higher 28-day mortality rate, usually if they had an underlying cancer. And a whopping 3% of people who presented with SIRS, which is not insignificant, went on to develop septic shock. So SIRS is associated with both infection and 28-day mortality. So if you have someone presenting with that to your ER, you need to take it moderately seriously. As you may have read, probably as punishment for throwing the election to George Bush. I said that deliberately. Some guy quit listening to my podcast because he's tired of me whining about George Bush. Get over it, he says. I'm never going to get over it. But Florida has the first extremely resistant tuberculosis. I'm sure the first of many. Now there's the MDR TB, which is TB that's resistant to INH and rifampin. There's the XDR TB, which is resistant to INH, rifampin, quinolones, and at least one of the other drugs such as amikacin, kanamycin, or capreomycin. And now they have XXDR-TB, which is resistant to all first and second line drugs that we use for TB. Then there will be the Van Diesel strain of XXX-TB, and only those over 21 will be allowed to have it. But you can expect to see more and more resistant to tuberculosis. Resistance is the wave of the future. And now comes the hodgepodge part of the podcast, the second most favorite part, the most favorite being the end. Remember, none of these will have references on the website. 1. In the study out of Sydney, Australia, circumcision did not reduce the risk of HIV in men who have sex with men. 3. Fooled you there, didn't I? Because I said 2 with the first one. Severe leptospirosis is associated with hypomagnesemia. Actually, I've seen this before in one case of severe lepto, where the calcium and the magnesium plummeted. This study had 14 patients who developed severe low magnesium levels in their first 10 days of illness. So keep a close eye on those divalent cations when you see leptospirosis. 4% of dogs in Denmark are positive for tick-borne encephalitis. Curiously, it's primarily on the Isle of Bornholm. Now, Bornholm's disease, or epidemic pleurodenia, is a Coxsackie virus infection. I haven't bothered to see if the island of Bornholm is associated with the name of that particular disease. But when you go to Denmark, be wary of a tick-borne encephalitis if you're on the island of Bornholm. There's a case of Lemierre, septic thrombophlebitis of the internal jugular due to Arachnobacterium hemolyticum. A nice, interesting case, since Arachnobacterium hemolyticum is not an uncommon cause of acute pharyngitis. Hey, guess what? Valve perforation during endocarditis is bad. It doubles the mortality, 30% versus 15%, compared to them what don't have valve perforation. And that the sooner you fix it, the better the patient does. There was a case of a patient who was on long-term linezolid for MRSA, and guess what happened? There was linezolid resistance that occurred. They had the same strain on 5 different cultures, so they knew it was the same genotype, but during the repeated exposures to linezolid, there was a single point mutation that rendered linezolid useless. In a wee bit of interesting evolution, there was an outbreak of Staph aureus in a football team. No big deal there, right? Well, it was an MSSA of the USA 300 strain, and they postulate that this was an MRSA that reverted to methicillin susceptibility and then caused an outbreak in the football team. So maybe the evolution or evolution of MRSA is a two-way street. There was an interesting case of someone failing their MRSA peritonitis with generic vancomycin. Then they switched to the brand name vancomycin, and the patient got better. The hospital became solvent. There was peace in the Middle East, and the lion laid down with the lamb. There have been times in the past where there has not been therapeutic equivalence of drugs, and this is an interesting example of what may be that case. Years ago in the annals, there was someone who had the red man syndrome with one brand of vanco, but didn't have it with another brand of vanco. So maybe all vancomycin is not the same. In a systemic review and meta-analysis, they couldn't be bothered with doing one or the other. They looked at the PCR for invasive pneumococcal disease and found it wasn't very good, with a sensitivity of only 57%, although quite specific at 98%. So it ain't that good a test in terms of finding pneumococcus. The same is true of the Legionella urine antigen test, which is very specific, but has a sensitivity of 0.74. So 26% of patients with Legionella will have a negative urinary antigen. Hey, guess what? Pollution increases your risk of pneumonia. Quelle surprise. That's why I don't inhale when I go to Los Angeles. Now, there's two types of pneumonia. Well, there's actually two types of people. Those that divide the world into two types of people and those who don't. I'm one of those people who doesn't divide the world into two types of people. But this looked at the difference between culture-negative hospital-acquired pneumonia and culture-positive hospital-acquired pneumonia. And patients who had culture-negative pneumonias did better than those who were culture-positive. So although culture-negative pneumonias are a pain in the arse because you don't know what you're treating, severity of illness, hospital mortality, and length of stay are decreased in patients who have culture-negative pneumonias. Just remember, and there's a nice review of this, that Streptococcus pneumoniae, especially in kids, although I've seen one case in an adult, is associated with hemolytic uremic syndrome, and specifically may be due to serotype 19A. Tracheostomies increase your risk of central venous catheter-related bacteremia. It's my impression that we're doing more tracheostomies in long-term ventilator patients. They found that patients with tracheostomies had a catheter bacteremia rate of 11.25 per thousand catheter days, compared with 1.43 in them what didn't. Also turned out that a jugular had higher rates of bacteremia than a subclavian, 21 per thousand catheter days versus 5.1. So if you have to put a central line in a trach patients, don't put in a jugular, or a jugular for that matter. Put in a subclavian. Not unsurprisingly, the faster you give patients antifungals, the better the mortality rates in the hospitalized patient. Giardia, at least in Norway, is associated with a post-infectious fatigue and abdominal symptoms for up to 2 years after getting Giardia. Most of these patients had severe giardiasis, and whether there's cause and effect here, one cannot say for sure, but certainly having bad gastroenteritis is associated with lots of long-term gastrointestinal problems in many studies. Guess what? This study, which was in Karachi, Pakistan, found that having contaminated well water was associated with an outbreak of salmonella. I wonder what Dr. Snow would have said. I wonder if Snow was a doctor. Well, he certainly found the first outbreak of cholera associated with contaminated drinking water, so this should come as no surprise. You'll be happy to know that drug-resistant Acinetobacter rates are up 300% in the United States. Go USA! Go USA! If you sneeze into your operative mask, you still will have positive cultures as snot and bacteria are blown out the side. They had a bunch of people wear surgical masks, and then they put pepper in their nose and made them sneeze and held culture plates to the side. And 8% of the time, they could grow bacteria as a result of the pepper-induced sneeze. So I think the take-home message from this is to ban the use of intranasal pepper in the operating room. Or maybe that's the wrong conclusion. And that ends our hodgepodge. And with the hodgepodge also ends our Puscast. Our, like it's yours. This is mine, I tell you, all mine. This has covered the last 2 weeks of December in 2009. We bid farewell to what was, in some respects, a crappy decade, and we move on to a new, probably equally crappy decade, just crappy in a different way. Now that you've listened to this, go take the quiz and get some free CME thanks to Legacy Health System. And participate in my worldwide multimedia empire. Listen to the Goblet o' Pus, my about every other day infectious disease vignette. Listen to the Quackcast, voted best healthcare Quackcast. Who says you can't fool some of the people all the time? Both available on iTunes. And while you're at it, write me a glowing review. Read my blog, Science-Based Medicine, where I contribute twice a month. And of course, Rubor, Dolor, Kalor, Tumor, my infectious disease blog over at Medscape. Because the world needs more Mark Crislip. Yeah, I know you've heard all this before, but bandwidth ain't free, so feel free to purchase the compendium and support this podcast. It's copyright 2010 under the Creative Commons license. The music is by my son when he was 12 years old, improvising on the guitar. I think I'm up to 2,200 unanswered emails. The chance of my ever replying to an email is vanishingly tiny. I can either write emails or write podcasts and blog entries, and I choose the latter. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you, and my presence has ensured decreased mortality in your patients. Thank you. In dictation, goodbye.